All right, y'all. Welcome to chapter 39. Guess what? Guess what? This is the last chapter we will be going over in this book. From here, your test will be Monday on AB Peds and Special Pops. Retest will be Thursday, and then all we have left is the final comprehensive exam. So, congratulations for making it this far. We've been kind of screwed on our classroom time because we've been having to do most of this online. All right. So today we're going to talk about chapter 39. It's geriatrics. Like everything else, we're going to go over the education standards, chapter objectives, key terms, the effects of aging on body systems, special geriatric assessment findings, and assessment-based approach. All right, your case study. EMTs Vic and Tina arrive at the scene of a motor vehicle crash to find a single patient, a woman in her 80s, still sitting in the driver's seat. The car struck a utility pole and has moderate damage to the front end, and the airbags have deployed. Upon making contact with the patient, Vic finds that she is confused, unable to answer questions appropriately. With the exception of a few abrasions on her face, there are no immediate obvious signs of injury. Okay. So, what are some of the first actions that the EMT should take? All right. Is C-spine going to be indicated in this? What would your scene size up be? Your general impression. How could the injuries received be affected by the patient's age? All right. Was she altered or unresponsive? Was she able to answer questions before she had the wreck? Does she have a history of dementia? Or was she not able to answer questions because of something that happened during the wreck? All right, these are all things we need to think about. All right, and what are some of the body's responses to injuries affected by the patient's age? All right, so geriatrics are at risk for injuries and illness, or at greater risk for injuries and illness. The changing physiology of the geriatric body system results in a different presentation of signs and symptoms. The geriatric patient often has one or more long-term conditions that might require multiple medications. All right. Some of the age-related physiological changes begin around age 30. It doesn't seem to be that old. Well, probably for a lot of y'all, that's like ancient. For me, it's not really that old. All right. People are living longer with chronic illnesses. All right. Medicine is getting better every day, every month, every year. We're making advances in medicine. Illness is common among the geriatrics, but not inevitable. Okay. The aging body has fewer reserves for acute medical and traumatic injuries. All right. So, changes in the body system of the geriatric patient. This right here should be in your book. It's a little bit too small for me to read on that screen right there. Okay. But some of the things that we're going to talk about, some of the things that we're going to see. As the heart grows older, there are fewer electrical conducting cells. These are your pacemaker cells, and the heart is less responsive to catecholamines in the body. This prevents the heart from increasing its rate when a greater cardiac output is required. Okay, so you may not see the higher heart rate, okay, like you do with younger adults and kids, all right? Just as other muscles in the body contract in response to an electrical impulse, the heart muscle contracts in response to electrical impulses created by the conduction system of the heart. With aging, there can be a general deterioration in the heart's conduction system, resulting in the inability of the heart to initiate and propagate a normal impulse. Okay, dysrhythmias occur. Electrical conduction is interrupted. In the geriatric patient, there is a decline in diffusion of oxygen and carbon dioxide across the alveolar membranes as alveolar surfaces progressively decrease. Chemoreceptors located in the aortic arch, in the carotid bodies, and on the surface of the brainstem that monitor the levels of carbon dioxide and oxygen in the blood become less sensitive over time. Just like with everything else, eventually, if you don't use it, you lose it, but if you use it too much, it wears out. All right. Another change is in the airflow in and out of the lungs. In a younger person, the smaller airways, which is the bronchioles, are supported by smooth muscle, which enables them to keep their open shape so that oxygen is easily inhaled with each incoming breath, and carbon dioxide is easily exhaled with each exiting breath. With aging, there is a decrease in both the number and strength of these smooth muscle fibers in support of the smaller airways. This results in a turbulent airflow, which diminishes airflow to the terminal alveoli during inspiration, can also result in air trapping during exhalation. The capability of the brain to monitor and regulate vital function, such as the rate and depth of breathing, heart rate, blood pressure, and core body temperature, can become deranged and not operate within the same efficiency during stressful times as in the younger patients. Okay, they're not going to be able to control things as well as a middle-aged adult, younger adult kid would be able to do. All right, sensory perception tends to diminish over time, including everyday senses such as auditory, visual, olfactory, which is smell, touch, pain, hot, cold sensations, and the body position. Neurologic changes, especially diminished vision and hearing, separately or in combination, can easily result in falls, automobile crashes, and other causes of injury. Neuropathy is any derangement or abnormal function of the motor, sensory, and autonomic nerve tracts. It could be diffuse, involving multiple neurons and simple and nerve tracts that affect many parts of the body, or focal neurons that affect single specific nerves and parts of the body. These findings include pain, numbness, tingling, swelling, muscle weakness, or even absent pain perception. This can further complicate the presentation of findings characteristic for a specific problem. You will see this neuropathy a lot in diabetics as well. Diabetes is very hard on your cardiovascular system. It's hard on your neuro system, and it's really hard on your eyes and your renal system as well. All right, because of the degeneration of the lining of the small intestines, nutrition are not as readily absorbed, further contributing to malnutrition. Fecal impaction and constipation are common because smooth muscle contractions of the large intestines diminish. In some, degeneration of the rectal sphincter can cause loss of bowel control. An increase in the level of hormone can increase blood pressure, and this is your endocrine system. All right, this is specifically talking about thyroid hormones, insulin. All right, you have vasopressor hormones such as epinephrine and vasopressin, which contributes to the development of hypertension, which is high blood pressure. The levels of certain hormones that help regulate the body's fluid balance, such as renin and aldosterone, become deranged and contribute to fluid imbalance, which has further effects on blood pressure. Collectively, changes to the endocrine system can cause elevation of blood sugar levels, alteration of blood pressure, and fluid imbalance. The disc located between the vertebrae of the spine start to narrow, which causes the characteristic curvature of the spine seen in 2 out of every 3 geriatric patients, known as kyphosis. This curvature is seen along the entire spine, but is usually most pronounced in the thoracic vertebrae and complicate spine motion restriction, especially if the patient is being secured to a backboard. It might be necessary to place additional padding under the patient to fill voids and create effective spine motion restriction. The ligaments that provide joints with stability start to weaken as well. The effects are diminished range of motion, range of joint motion, possible pain with movement, and increased risk of joint injury. This is where that Alter gets in there and gets in their joints and stuff. Trust me, I know all about Alter. He's visited me a few times. All right. Because of the diminished kidney function, altered GI absorption, and altered liver function, geriatric patients are more susceptible to toxicological emergencies. Other factors that can place the geriatric patient at an even greater risk of toxicological emergencies include poor eyesight, medication noncompliance, polypharmacy. They go to different pharmacies, and this pharmacy doesn't know what the other pharmacies give them, so they're having drug interactions. All right. Loss of integrity of the blood-brain barrier and poor motor skills. As the skin breaks down, there is a tendency for sores and tearing injuries to occur. This diminishes the effectiveness of the skin as a proactive barrier in keeping microorganisms out of the body. Also, skin is the major organ of thermoregulation. Therefore, hypothermia and hyperthermia are more likely in geriatric patients. All right, the patient or EMT might underestimate the severity of the patient's condition. The EMT must be able to recognize these emergencies and provide appropriate medical care. All right, heart attack. Instead of presenting with chest pain, the geriatric population will have what's known as a silent MI, just like your diabetics, your elderly, your women, okay? They will present with weakness, fatigue, confusion, dizziness, nausea, vomiting, abdominal pain, syncope, and possibly even trouble breathing. Trouble breathing is also a common initial complaint, although 1/3 of geriatric heart attack patients never experience pain, aching shoulders, but indigestion is common. Emergency steps for a suspected heart attack are to administer oxygen via nasal cannula at 2 liters per minute. If the SpO2 is less than 94, if there are signs of poor perfusion, hypoxia, heart failure, or the patient complains of dyspnea, administer aspirin and nitroglycerin as appropriate with consultation with medical direction, and transport the patient expeditiously but cautiously to the hospital. All right, congestive heart failure can be acute or it can be chronic. Acute means a new onset, a rapid onset. And what exactly is congestive heart failure? It's where your heart is not pumping properly. So the heart doesn't move the blood forward, it backs up. All right, it backs up in the lungs, it backs up in the lower extremities. Okay. Congestive heart failure can be a chronic condition that the patient might tell you about during your history taken, or it can have an acute onset and be the cause for the geriatric person summoning EMS. Congestive heart failure is primarily caused by cardiac disease. It can present differently than a heart attack. It is caused by a heart that becomes weakened over time because of the changes in aging, as well as hypertension, arteriosclerosis, disease, dysrhythmias, which is abnormal heart rhythms, and heart valve damage. Emergency care steps for CHF include administering oxygen, placing the patient in a Fowler's position, and expedient transport. Be sure to watch for inadequate breathing and be prepared to ventilate. All right, a lot of these people are not going to be able to lay flat. All right, this is called nocturnal dyspnea. All right, they get short of breath at night. They have orthopnea. They cannot lay flat. Some of the common causes are pulmonary edema, pulmonary embolism, pneumonia, and CHF. Breathing can very easily become inadequate. All right. There's a chart in your book, some of the most common causes of shortness of breath in the geriatric patient. All right. It can range anywhere from pneumonia, a PE, chronic bronchitis, CHF, emphysema, asthma, heart attack. It's pretty much a rule one out, move on to the next. Okay. Pulmonary edema or fluid in the lungs can have a gradual or sudden onset and can result in death if proper emergency care is not provided. Emergency care includes administering oxygen to maintain an SpO2 of 94 or greater, placing the patient in Fowler's, monitoring for inadequate breathing, and transport. CPAP can be administered if the patient is in significant respiratory distress where the SpO2 cannot be maintained at 94%. I would recommend going ahead and putting these people on CPAP, okay? If they can tolerate it, give it to them. I've seen the CPAP turn people around in as little as 10 minutes, okay? Usually these people are going to be intubated and stuff, and this allows them to stay off a ventilator. Poor gas exchange and respiratory distress result. A large clot may prevent blood return to the left heart, resulting in hypotension. With large clots, the blood cannot make it from the right side of the heart to the left side, and hypotension ensues. You might also notice localized wheezing to one of the lungs, and with blockage, the pulse ox might drop dangerously low. If a large embolism occludes more than half of the pulmonary circulation, it can cause rapid death. Some of the predispositioning factors include aging, smoking, cancer, fracture, surgery, cardiovascular disease, prolonged bed rest, and trauma. All right, we're going to treat these the same way. Maintain an open airway, monitor for adequate breathing, maintain an SpO2 of greater to or equal than 94%, positive pressure ventilation, transport, and request ALS. All right, aspiration pneumonia often results from accidental aspiration of food and vomitus into the lungs. This is why preventing aspiration of foreign material is so important in the maintenance of the geriatric airway. Pneumonia tends to strike when multiple risk factors are present. Some of these include advanced age, being bedridden at home or institutionalized, immune system compromise, a history of other pulmonary diseases, cancer, prior stroke, or a history of inhaled toxins. Emergency care is primarily supportive and includes maintaining the patient's airway, administering oxygen, and maintaining an SpO2 of 94% or greater, and transporting the patient in a Fowler's position or position of comfort. All right, COPD is a disease complex that includes many individual pulmonary disease processes, principally chronic bronchitis and emphysema that result from the gradual deterioration of the pulmonary structures. All right, transport the patient in a position of comfort, which will usually be Fowler's, which is sitting, because the COPD patient can become easily fatigued from the effort of breathing. Monitor the patient closely for signs of inadequate breathing. If breathing becomes inadequate, positive pressure ventilation with supplemental oxygen. The patient can have an altered mental status from some chronic conditions such as Alzheimer's disease or from an acute onset of the primary emergency such as a stroke. Okay. We also want to be thinking about dementia, the Alzheimer's that we talked about, maybe a UTI, diabetes. All right. Never assume that the patient's altered mental status is normal for them or that it is what happens when you get old and risk missing an important sign of an illness or injury. Okay. All right. Check this out in your book. All the reasons that you can pretty much think of for an altered mental status. All right. Cognitive impairment. Severe cognitive impairment can cause the patient to lose the ability to understand the importance of something and the ability to talk or write. There is a higher morbidity and mortality associated with an impaired cognitive state. Therefore, it is important for EMS to identify the condition. The key in emergency care of patients with an identified cognitive impairment is to ensure that they can take care of themselves and are in an environment in which adequate resources are available to take care of them. All right, a stroke. A stroke occurs when there is an interruption in blood supply to an area of the brain when a blood vessel in the brain becomes blocked by a clot, obstructing blood flow or ruptures and enables blood to accumulate in the brain tissue. Other signs and symptoms: unequal pupils, slurred or abnormal speech, headache, memory problems, altered respirations, increased or decreased heart rate, hypertension, seizures, nausea, vomiting, muscle paralysis or weakness, and sensory loss. Okay. Emergency care steps should include protecting the airway, administering oxygen, and suctioning as necessary to prevent aspiration. Transport in Fowlers, or if they're conscious, or lateral recumbent if they are not conscious. All right. And we always want to check a blood sugar. All right. So, a TIA, no permanent neurological dysfunction occurs with a TIA. This is a transient ischemic attack. This is caused when blood supply to an area of the brain is temporarily occluded, causing a malfunction of brain tissue that is not being perfused. A sudden and temporary alteration in mental status is caused by massive electrical discharge in the group of nerve cells in the brain. This is where you get seizures. Some of the common causes of seizures are cardiac arrest, low blood sugar, tumors, head trauma, stroke, TIA, infection, and electrolyte imbalance. So for seizures, you're going to want to place the patient in the recovery position to help prevent aspiration if they are unresponsive and if no trauma is suspected. Make sure they cannot hurt themselves. Monitor their airway and suction as needed. Maintain their SpO2 greater than or equal to 94%. And provide positive pressure ventilation if breathing is inadequate. All right, syncope. This is like passing out. You'll hear this is a syncopal episode. Done fell out is a common one. Syncope is a temporary loss of responsiveness that usually reverses when the patient is lying down. If the patient suffered a fall with the syncopal episode, they should be assessed for a possible spine or spinal injury. All right, we want to make sure they have an adequate airway, maintain their SpO2 at greater than or equal to 94%, apply positive pressure ventilation if breathing is inadequate, and place the unresponsive patient in the recovery position. All right, we talked about this HHS, hyperosmolar hyperglycemic syndrome is a diabetic complication that is more common to geriatric patients with diabetes. Okay, it's pretty much the same thing we talked about. The blood glucose shoots up because they don't have enough insulin present, and dehydration occurs from the excessive urination. Remember, water follows sugar, just like it follows sodium. All right. The geriatric patient with HHS most likely presents with an altered mental status, typically with a gradual onset, possibly progressing over a day or two, a possible history of diabetes, and an elevated blood glucose level. Management includes positioning to protect the airway, supplemental oxygen, and maintain an SpO2 reading at 94% or greater. Positive pressure ventilation if the patient breathes inadequately, and circulatory support. You also want to consider ALS intercept. The geriatric population takes approximately 1/3 of all prescription medications. They also buy the greatest number of over-the-counter medications. Because they tend to have many coexisting diseases, they are at a greater risk for drug interaction from prescription medications. All right, delirium and dementia. All right, it is a chronic and irreversible and can be severely worsened by infection, medication change, trauma, or another acute condition. Changes in mental function are normal with aging, but approximately 15% of those over the age of 65 develop severe dementia with profound disturbances in cognition, including loss of short-term memory and the decline in judgment, intellectual ability, and abstract thought. Delirium can also result in an alteration in mental status, but unlike dementia, which is a chronic condition, delirium presents with a more recent and sudden onset. Delirium is often described by family members as starting abruptly and can present with delusions. The patient might have a history consistent with a delirium episode, which can include intoxication or withdrawal from alcohol, sedative use, infectious medical conditions, dehydration, fever, stroke, blood sugar level abnormalities, a psychiatric disorder, malnutrition, hypoxia, endocrine disorder, or even an environmental emergency. The treatment of patients suffering from Alzheimer's disease is any other form of dementia requires special compassion from the EMTs. Naturally, you must take necessary action to establish and maintain the airway, breathing, oxygenation, and circulatory system. But often you will transport these patients in a non-emergency setting. At times, you might find the patient uncooperative, even combative, with biting, spitting, and punching. It may help to enlist the assistance of a caregiver or person that trusts. Remember that the uncooperativeness and aggression... Hush! Sophie! Soph! Remember that the uncooperativeness and the aggression are symptoms of the disease